Hi, I'm Dr. Shivani Chandhan, consultant obstetrician and gynecologist at Aster Hospital, JP Nagar, Bangalore. Pain is a symptom that nobody wants to go through. Pain during periods, which is also called as dysmenorrhea, is one of the most commonly reported menstrual problems. And more than half of the women suffer from this problem. That is why we are here to discuss about this condition called dysmenorrhea. We will discuss it through various case scenarios so that people know what has to be done in each situation.
Hi, I'm Dr. Sunil Eshwar. I'm the lead consultant Obstetrics Gynecology at Aster JP Nagar. As Dr. Shivani already spoke about the topic, we wanted to discuss what's normal and what's abnormal. No pain is normal. So what we're going to discuss is if this pain during period, which we call it as dysmenorrhea, is caused by a normal issue or there is any abnormality. Most of the time, if the pain starts as early as her menarche, then it is called as primary dysmenorrhea, and many times there is no reason why there is this pain. So this is because of some hormone like prostaglandins and progesterone secretion in the second half of the period, which brings about the pain. Whereas secondary dysmenorrhea, there has to be some reason why there is the pain coming in. Secondary dysmenorrhea is described as a pain which was not existing before, has suddenly started coming, maybe after 5 years or 2 years, that after her menarche, the woman start experiencing the pain. So as there are different causes for secondary dysmenorrhea, the most common cause being infection, pelvic inflammatory disease, endometriosis, fibroids, and adenomyosis. So we try to discuss few of the case scenarios where we regularly, interact with our patients regarding this condition. So,
So now that we know that we have two types of dysmenorrhea, the first clinical situation where what we come across most commonly is, the mother of a 13-year-old child has come to us saying, "Doctor, my daughter attained her, first periods around 6 months back. And from the second or third period, she has severe pain. And on the first day, she's not able to go to school. She's just constantly lying down. She even has vomiting sometimes. Doctor, I'm really concerned because I never had it. My daughter is really struggling. What should I do about it? Is it worrying? Could it be because of some problem?"
As this patient is from the time of her period, she started having the pain. So this is fits into criteria of what's called as primary dysmenorrhea. But as we say, what is significant pain? Any pain which can compromise on the daily lifestyle of the patient, a person. Like, you're not able to go to the office, you're not able to go to school, or you're not able to do your daily routine work, then it is a significant pain. So in this child, she's not able to go to the school. So, and from past 6 months, that from the time of her menarche. Though, as we say, primary dysmenorrhea or the primary pain of the periods does not have any known causes fits into the criteria of primary dysmenorrhea. We still have to sometimes investigate or do certain tests to rule out that there is no other pelvic causes which is causing the pain. See, primary dysmenorrhea, by history itself, we will be able to tell, yes, there is no any cause, like, they are associated with pain and significant increase in the pelvic problems later on. So we need to have a very good abdominal scan or pelvic scan with the full bladder to see if her uterus ovaries are normal. If her uterus ovaries are normal, then we need to just reinforce the mother and the child that it's all fine. We will have to give her some multivitamins and some anti-inflammatory medicines which can take during her periods. And some multivitamins are known to reduce the intensity of pain and the premenstrual symptoms of vomiting and breast pain. So this is
quite common, wherein the pain usually comes down after the first and second day, and it's very common in the initial cycles, right?
So similarly, we do get some patients. Another case scenario which we want to discuss is this is a girl who is 22-year-old, not married yet, is complaining of severe pain during her periods, which has been increasing now from past 6 months, and she is not want to follow her career and wants to settle down. So she has come here for a consultation. So
Considering that this lady, who's a 22-year-old, has not had this pain initially, in the initial years after attaining her first periods, she's not had this pain, and this is something that is new onset. Definitely, she has to be looked into the nature of the pain. Is the pain remaining throughout the periods, and is it affecting her daily routine? And since she presents with these kind of complaints, the first thing we will do definitely is an ultrasound. We will look at the uterus, at the ovaries. She could be presenting with any of the conditions that Sir has already mentioned, like a small fibroid uterus, or she could have a condition that is endometriosis. Infection is quite unlikely, saying, looking at that she's sexually not active yet. But endometriosis is a condition that can be diagnosed, but also is difficult to diagnose on the scan, which we will see with other situations as well. So, what is the cause for this pain? And then accordingly treat her with, pain relief medications if she requires additional hormonal medications. So, further will be decided only after doing a scan.
So, as the history itself is quite obvious that patient is describing an increasing pain. So every month there is some amount of increasing pain. Here we need to kind of ask the types of pain. There are two types which we generally try to categorize. One is called a spasmodic or a squeezing kind of pain, and other one is a heaviness or a pricking kind of pain. The squeezing kind of pain is usually associated with fibroid, or there is any septum or any polyp in the uterus. Whereas dull aching or pricking kind of pain, which is throughout the periods and during all the days of menstruation or few days before menstruation, is associated with endometriosis. As we know that endometriosis can be diagnosed with scan, but early stages of endometriosis, or what is another condition called as adenomyosis, cannot be diagnosed with a scan. So in this situation, we may have to resort to higher imaging modalities like MRI. MRI can pick up or even categorize what is adenomyosis or endometriosis. But many a times we tend to give treatment depending upon the clinical situation and the history wise. Because as she is unmarried, it is very unwise for us to put her through any surgery, as we are not seeing any abnormalities either in the uterus or the ovary. Yes, if we do see any problem in uterus or ovaries, we may think about surgical approach, but that is also can be managed most of the time as she is very young, 22-year-old. So we would rather manage medically than do any surgical treatment in this patient. So coming to another case scenario, like this is a 25-year-old woman who has been married for past 4-5 months, and now she has started having pain during her periods. This is only from past 3 months from the time she is married. And she also complains that she feels very tired during her periods, and she is a little bit feverish during the period. What do you think this case could be?
Considering here the important difference from the previous case scenario is that she is married and she's developed this again new onset, which was not there previously. So there is a high likely chance that it could be pelvic inflammatory disease, wherein there is infection which has entered into the uterus and affected her tubes. And this infection and inflammation has led on to causing this severe pain. So this is a condition which can be treated easily. Again, we will do an ultrasound if required to look at the uterus and ovaries just to make sure about a diagnosis. It can be even diagnosed clinically just by examination, where the patient has severe pain when we do an per-vaginal examination. So considering this condition, it can be treated with a course of antibiotics and good amount of painkillers and antispasmodic medications. So that is what we would do for this condition.
So in this situation, patient is married from past 4-5 months. Some of the clinical points which we would like to look into, whether her white discharge has increased. Any white discharge which is foul smelling, itching or frothy, or discharge which has turned greenish would indicate that there is some kind of a vaginal infection. Sometimes even curdy white discharge can be there, which we call maybe due to fungal infection. So if she has a history of this kind of a recurrent white discharge which is itching or foul smelling, that probably indicates to us a pelvic infection. This can again, as we know that we can do an internal examination, pelvic examination, to see if there is any vaginal infection, which would again indicate towards a pelvic inflammatory disease. One thing which I would really stress on when we are treating a pelvic inflammatory disease is please complete their antibiotic course. We've seen quite a number of patients where they start the course, in 2-3 days they will have the relief and they stop it. So what happens is if you are not taking the antibiotic or the prescribed treatment properly, there will be internal damages to the pelvic organ which can happen and which later on leads to difficulty in conceiving, what we call it as subfertility or infertility. Because this infection can damage the tubes, it can damage the internal pelvic architecture, it can form adhesions, or it can form abscess or pus inside. So, when a doctor prescribes antibiotic, it is always mentioned how many days to be taken and what is the next thing to do. They have to follow particular menstrual hygiene, which is very, very important to avoid recurrence of this infection and causing the long-term side effects of infection.
Yes. And the other thing is not to take medicines over the counter.
Which can commonly happen.
Yeah. So that results in partial treatment also. So moving on to our next scenario where we have a 30-year-old female who has been married for 2 years. She used to have some amount of pain earlier, which was bearable and used to come down with medications. But she gives significant history that the pain has increased since 6 months. And because her pain was really intolerable, she herself went to a diagnostic center. She got a scan done. The ultrasound, the person who did the ultrasound told her that she has something called an endometriotic cyst, which is around 4 centimeters. Now she says she doesn't want to conceive now. She wants to conceive only after a year. So what is this condition? Can you just describe it, sir?
So endometriosis or endometrioma is a quite very common condition which we see nowadays in young women or reproductive age group. Endometriosis is a condition where, as we all know, uterus has a lining called as an endometrium, which is responsive to the hormones produced by the ovaries, to estrogen and progesterone. This endometrium, as we know, every month has to be shed and then you have the menstrual periods. Similarly, this endometrium can get implanted inside the pelvic cavity, like inside the ovary or in and around the uterus, on the uterus ligaments which support them. And then it starts growing inside because, as I said, these tissues are responsive or they respond to the estrogen and estrogen hormones. So every cycle, these small tissues grow inside, and when the period happens, they also bleed inside. So when there is internal bleeding which happens, that's why they get so much of pain. And as it keeps growing by period to period, the pain intensity, duration also increases. So if this endometriotic patch implants inside the ovary, then when it starts growing, we call it as endometrioma. As we know, ovary is an organ which produces the eggs, and from where the eggs are released, and that's how the fertility or pregnancy happens. Endometrioma will compress the eggs, and as it keeps growing inside, it's in a closed space. As it grows, the pain also really very high as the size of the cyst grows. Now, in this situation, this patient is now career oriented, wants to plan a pregnancy for 1 year. One thing which we try to avoid in this situation is a surgery. Considering the size of the endometrioma is 4 centimeter, anything more than 4 centimeters, we do say, by books you require surgery, but we have to see in the light of whether she wants to conceive early or not, because endometrioma is a recurrent, endometriosis is a recurrent disease. So it's not that we can completely eliminate when we operate or remove all this tissue. It's likely almost 25-30% of the patient would get this endometrioma or endometriosis back. So when we operate, we also make sure that they are planning to conceive as early as possible. So if the patient's duration is 1 year not to conceive, then probably we would like to put them on some medical management, which would reduce the pain and also the cyclicity. Okay. So over a period of time, yes, if her pain is not relieved or the cyst has grown really big inside, means if the 4 centimeter becomes 6 centimeter or 7 centimeter, then probably yes, we would still think about it and also counsel the patient that look, we have a situation, we are operating, but then we do understand that the career is important. If you are very so much keen on having a family, plus yeah, you need to try for having a family. Or if we need to do also what's called as an ovarian reserve test to see how much is the egg reserve which this woman has. As we all know that the woman's in the biological clock, the number of eggs over a period of time as the years pass by reduce. So to make sure that she has enough number of eggs in the store, then we can counsel them as to when to get pregnant and how much long they can avoid being pregnant. Once we operate on endometrioma, there is certain loss of ovarian tissue or eggs during the surgery. So we cannot go on and on operating on this if there is a recurrence. So in that situation, we would rather want them to conceive early. Okay. Or if the patient wants to really prolong and say, okay, no, I'm not very much interested, I may come back after 4 or 5 years of it, they can also consider another option called as oocyte freezing or embryo freezing. They can create embryos and so that the good embryos which happen in the early ages can be freezed for the future use. They can have this pregnancy. Now she is 29 years old. So even if she wants to come back after 4 or 5 years, she can still use those embryos with her. Endometrioma, as I already told, it's a progressive disease. We need to have a very, what we do in Aster is we have both a team which manages the pain as well as the condition. So, because this pain is so unbearable, there is lots of psychological problems associated with the patient. So we do also have counselors. They have to see have certain more counseling sessions. Yes, yoga, exercise, being active, all helps to reduce this. But a group consultation for the disease progression is always better.
Another important thing that people need to be aware is that it can be treated laparoscopically. The importance of laparoscopic surgery in endometriosis is very important. That it can be treated on a daycare basis where the patient doesn't need to stay for long. The condition there's no need to do. Certain people have come to us and say, doctor has told, somebody has told that we have to do open surgery so that everything can be cleared out. So that misconception has to be cleared out.
Yeah. The laparoscopy is always better than the open surgery in this condition because laparoscopy few advantages are there. One is, as we know that we infuse the gas and the abdomen is inflated, so the space is more. One. Next is laparoscopy works on magnification. So we do have certain amount of magnification of the tissue. So any small pathology can be easily identified and operated. The most dangerous complication of endometrioma operations are one of bowel injury. Another one is where we can injure the ureter. Considering the ureter and bowel are very much, ureter passes the pelvic cavity, many a times we find that the endometriosis or endometrioma has got infiltrated into lateral pelvic wall, which can even be attached to the ureters. In laparoscopy, we have such a nice magnified view that we can very easily, it does take some time, separate the ureters and make sure that the damage doesn't happen. But in the open surgery, what happens is that you do not have that much amount of magnification, and the dissection is a little bit faster. So there is a likelihood of injury to the ureter which happens with the open surgery. Laparoscopy, another advantage is, as most of these women are young women or working women, laparoscopy gives you an advantage of returning back to your work faster. So I think laparoscopy has majorly changed the way we look into endometriosis nowadays. Yeah.
So another misconception about endometriosis, does having an endometriotic cyst always mean that patient has to go for IVF?
No. That's another misconception which you have. Endometriosis, as I said, how we plan is that if the patient comes with anxious to conceive, first 3 or 4 months we just try with the normal methods of conception. If she is not able to conceive, then we may plan a surgery to remove the endometrioma. There is lots of pelvic distortion which happens when in patient who has endometriosis. Means to say the uterus may be adherent to to lateral pelvic wall or to the posterior wall of the pelvis. The tubes may be stuck somewhere, so there may be some kind of salpings which can happen because of the mechanical compression. The orientation between the tube and ovaries might have changed. So the the laparoscopic surgery corrects all these defects. We remove the endometriomas, we fulgurate the endometriotic implants, and we try to correct whatever the distortion of the uterus to tubes which happens. So we have seen quite a number of patients conceive following this procedure. But as I said, if the patient is undergoing a surgery for endometriosis or endometrioma, we have very streamlined protocol where in the first 3 months we try for normal. If she is not conceived, we try a few cycles of IUI. Over this period of time, usually around 60-70% of our patients conceive. Once you don't conceive, yes, you may have to think about IVF. As I said, it's a progressive disease. If the endometrioma recurs, then operating on you again, removing those endometrium will again compromise on your ovarian reserve, the quality of the eggs which you're going to get. So it's always wise that within 6 months or 7 months we plan your pregnancies.
So we have spoken about endometriosis in a reproductive age group. So what if a lady who's around 40 to 45 years comes to us and she has the typical symptoms? We have seen that she has a huge endometriotic cyst on both sides. How should she be managed?
So this again will depend on the size of the endometrium. One, if the endometriotic cyst size are larger than 6 centimeters, then we would probably again think about the surgery. If the size is not much, then there are certain other medical methods you can try. One of the other methods is, as we know that this pain start or the issues start only with the periods. So we have this beautiful device called as Mirena or intrauterine progesterone devices, which we can insert inside the uterine cavity and can be used for the period of 5 years. So for that 5 years, they will not have that much pain or bleeding. But as we know that there is endometrioma, we need to keep her on follow-up by doing serial scans to see if the size is really increasing. So what I would say is, case to case, the situation varies. Endometrioma, not necessarily every endometrioma has to be operated. We also get one more situation, I would say, we have seen quite a number of patients coming with endometrioma with the blood test called as CA125.
Yes.
CA125 is a marker for ovarian cancers, one of the markers, we would say, but it is a non-specific marker. As there is inflammation in the pelvis, CA125 is generally a little bit raised. So many patients do have a concern telling that it could be a cancer which is growing. So we have not, as I said, transvaginal ultrasound or an MRI can really pick up a lots of information regarding whether it's a cancer or not. CA125 is definitely not a best indicator for surgery on an endometrioma. As we have very much discussed on endometriosis, endometrioma, I think people can reach us out on this on our website if they have any more queries. Another case scenario we would like to discuss in the last. There is a 38-year-old woman who has 2 children, and last childbirth was around 5 years back. And during her pregnancy, they told that she had small fibroids in her uterus. Now presents with increasing pain during periods, and with the pain, her bleeding also has increased. So, what would you think this case scenario would be?
See, as mentioned earlier, the nature of the pain. Usually, when they have fibroids, they present with spasmodic type of pain. So, considering she knows that she had multiple small fibroids during her second pregnancy, and now she's having severe pain and associated with increased bleeding during her periods. So, we need to look at how these fibroids have grown over these last 5 years. Where is the location of these fibroids? See, first of all, fibroids is a condition where there is abnormal growth of the muscle of the uterus. Right? These are benign, these are not cancerous, not always cancerous. These are benign growths in the uterus. So condition can be treated based on the age. In this case, she's a 38, around 40-year-old. So we look at the location of the fibroid. Where is it in the uterus? Is it towards the cavity? That most probably it is towards, because that she's having excessive bleeding during her periods. Or is it the multiple fibroids? So how big are the fibroids? And based on this, we will decide what further has to be done. So not all fibroids require surgery. So we can treat small fibroids with medication. These can be medications to control the bleeding and also the pain. With this, if the bleeding and pain is controlled, we just need to observe the size of these, monitor it serially, maybe once a year we can do scan if the fibroid is small. After this, if she's not responding to these kind of medications, we can give her hormonal treatment as well, hormonal medications too. These will, stop the fibroid from getting bigger. If the cavity is not indented too much by the fibroid, we can also go for a Mirena, like how sir has mentioned earlier. A Mirena also would help in a fibroid uterus. And finally, if the fibroid size is too big and if it's indenting into the cavity, we can do a surgery called myomectomy, which is just removing the fibroid and not the uterus as a whole.
Truly, as she's 38-year-old, we would not want to remove the uterus. Whereas patient needs to understand that fibroids are de novo coming out of the uterus, or they are developing inside the uterus. Myomectomy is where only the fibroids are removed. A laparoscopic surgery has lots of advantages, as we already spoken, but there are certain disadvantages to it also. We will not be able to pick up any fibroid which is less than 1 centimeter. So there are likelihood that we may miss some fibroids in the uterus. So over a period of time they may grow. So whenever we operate on a woman who is still younger than 45 years of age for myomectomy, we do counsel them that they have to come on a regular follow-up basis, once in a year at least, to see if any fibroids are growing. If fibroids are picked up in the early stages, we can definitely put them on some medical management so that they don't grow very fast. They grow at a rate of 1 to 2 centimeters per year. So someone who is around 40 years of age and has undergone a myomectomy, and we know that average age for women in India to attain menopause is around 47, 48 years of age, we could still manage her with a medical management. Yeah. So another question which they keep on asking us is, I have fibroid in my uterus now, and I'm 45-year-old. Now, what will happen to this fibroids? Do I get it operated or do I don't get it operated?
See, when you're, this is all based on the symptoms first of all. There are many patients who may have fibroids but don't have symptoms. So definitely we decide this based on symptoms. Are you having excessive bleeding? Is the pain severe? Then secondly, what is the size of these fibroids? If the size is small and you're 45, and like sir mentioned that it grows around 1 to 2 centimeters every year. So if it's not disturbing you and you reach menopause, the fibroid will regress by itself. So surgery is definitely not indicated in all cases. We have to look at the size, the symptoms, and then only plan surgery.
Will it become cancer later on?
There is not all fibroids. There is only 1% chance that a fibroid can be cancerous. So we see the growth. If it is cancerous, it will grow rapidly and the blood flow will be more. So if these features are not there and if it's the same size, that's why we said, serially monitor the size of the fibroid.
Right, listen. See, how I put it is, any part of your body, any organ in your body can become cancer. It could be lung, it could be breast. As we know, the breast is the most common cancer in the women. A fibroid turning into malignancy is less than your normal breast tissue turning into malignancy. So it's not that once it's finished its function, we need to remove the uterus. We do know there are certain drawbacks of this. So hopefully we've covered most of it. But I know there is lots more to cover in this. One thing which I would like to tell everyone is that most of the women do suffer some kind of a pain or not during their life, because of the periods. But it's not wise to suffer your pain silently. Do come have a consultation with us. Not every pain needs a surgical management. Most of it can be managed either with a counseling or a little bit of change in a lifestyle or probably a little bit of anti-inflammatories. So it's my humble request to all the women, whoever is suffering from any kind of pelvic pain during periods, to have one good consultation and solve it. Thank you.
Thank you.